In terms of ions, we're going to talk about like how ions, if they're out of balance, how that's going to have implications in your normal day-to-day physiology. So one of the most important ions in the body, of course, is going to be sodium, right? Sodium is crucial for so much, including, well, actually, let me ask you guys, what's really important when it comes to sodium? Huh? Sodium is important for what? Think think about voltage-gated sodium channels. Action potentials, yeah, so depolarization. So if you don't have sodium, you're not going to be able to have a proper action potential, right? And so you wouldn't be able to have proper functioning of your neurons. Same thing with your cardiac myocytes, right? Your SA, as well as AV node, those wouldn't be able to work properly without proper levels of sodium, right? Because sodium is going to be important for depolarization, right? Then repolarization, potassium is the other really important one too. So in other words, sodium and potassium are some of the most important ions in our body. It's important for some of the most important physiological activities, depolarization. If you have changes in your sodium levels, the fancy term is hypernatremia for too much sodium and hyponatremia for too little sodium. And things that help to, well, other things that are important with sodium is the tonicity of your extracellular fluid, right? And so we're going to talk briefly about how fluids can be thrown out of balance if you give the wrong type of fluids, right? So for example, if a patient hemorrhaged and they have low blood volume, you want to give them fluids that are, higher in solutes, that are higher in things like sodium, for example. You wouldn't want to just give that person pure water because that's going to throw their solutes off of balance. So giving somebody a hypotonic solution, as an example, might mess with the blood cells, erythrocytes. It could cause swelling of the red blood cells, which we'll talk about in a second. So maintaining tonicity is really important. And then, of course, nerve conduction is really important when it comes to sodium. So if you can't produce an action potential, you're basically going to be super lethargic. You might go into coma and you might eventually die. And then the renin-angiotensin-aldosterone system, which I'm sure you guys are very fond of when it comes to AMP. So the RAS system is extremely important, right? So if your blood pressure goes down, what happens at the level of the kidneys, at the juxtaglomerular cells? What gets released? You guys remember? Yeah, renin gets released, right? And renin is going to help convert angiotensinogen into angiotensin 1, right? And then eventually at the lungs, you get ACE, right? Angiotensin converting enzyme, converting angiotensin 1 to angiotensin 2. One of the things that angiotensin 2 does, right? Vasoconstricts, but it also helps to release aldosterone. And aldosterone is going to do what at the level of the kidneys? So distal convoluted tubules and collecting ducts. Huh? Yeah, both, right? So it's going to allow for reabsorption of sodium, and then water follows solutes, so then you're going to be able to increase your blood volume as a consequence. And then atrial natriuretic peptide, as well as brain natriuretic peptide, is also going to be involved in maintaining balance of sodium in the body. So it's going to do the opposite. It's going to help to excrete sodium, right, if your blood volume is too high. Okay, so this is what your blood would look like if you were to subject it to either a hypotonic or a hypertonic solution. So generally you want to give a person isotonic solution. So back during the days of Vietnam, there was something that was really interesting that was done for people that needed to have IV fluids. If they ran out of IV fluids, what would they be able to use instead? On a tropical island or a tropical environment? What's something that's abundant in like tropical places? Huh? Seawater. I don't think seawater would be a good idea just because there's so much crap in seawater. Huh? Coconuts, yeah. So they actually used to use coconuts to replenish an individual's fluid. So you can like stick a little needle into the coconut, put the other needle in the person's arm, and you can actually replenish their IV fluids using coconut water. Because coconut water is an isotonic solution. It has a similar amount of solutes as we do in our plasma. So you can use coconut water. If you gave a person a hypotonic solution, if you gave them just water, right, no solutes in that, then what happens? Because of osmosis, right, water follows solutes. There's going to be more solutes inside the red blood cell. Water is going to enter into the red blood cell. The red blood cell gets thicker, it swells, and then you can also see lysis. So it's not shown in this image, but it can swell to the point where it pops. Okay, so that's not a good thing. So you can cause hemolysis if you give a person a hypotonic solution. So you don't want to do that. You also don't want to give them a hypertonic solution where it's way too many solutes, because then that can cause shriveling up of those erythrocytes. So it's good to understand what tonicity is, what osmolarity is, right? So osmolarity and tonicity, the higher it goes, the more concentrated that solution is, right? A hypertonic solution means it has a lot of solutes in it. Same thing if it's high in osmolarity. And then the opposite, of course, is true too. Battery dying on my thing? Dang, what's going on there? Okay, so here's another depiction of what that looks like, right? So you have normal osmolarity, so that would be like an isotonic type of scenario. Now, if you had reduced amount of sodium, then what's going to happen to that? That becomes a hypotonic solution, and you're reducing the osmolarity. Dang it, I was supposed to ask you what that does. So what would this be called? Hypernatremia or hyponatremia? Huh? Hyponatremia, great. What about over here? If you increase the amount of sodium in that, is that hyper or hyponatremia? That's hypernatremia, great. Let's see if it's... Let's do it where it's at. There we go, now it's working. All right, so hypernatremic, is that hypo or hypertonic? Huh? If it's hypernatremia, is it hyper or hypotonic? Hypertonic, and that would mean that the osmolarity is up, right? It's going up in that scenario. All right, now if you change the levels of water, okay, so say for instance, you're giving a person extra water, right? You just gave them an IV solution that's just water, nothing else. So what happens to the osmolarity now? Is it, yeah, great. So the osmolarity is going to go down. Now it's going to become an overall hypotonic solution. The plasma becomes hypotonic. So the osmolarity goes down. And then what happens to the amount of sodium? Yeah, now they're considered hyponatremic. Even if they had the same exact amount of sodium as they did prior, now that you added more water to it, you're diluting it. So basically you're inducing a state of hyponatremia. What happens if a person is super hyponatremic and all of a sudden, like say for instance, you're hiking through the desert. That's a bad example. What if you just got, you were challenged by a friend? Actually, there's a real thing. The water challenge where you like see how much water you can drink. People have died from that. You can actually die from water toxicity. This is the fundamentals to water toxicity. If you drink too much water, you dilute your blood, right? So you're diluting the amount of solutes in there. What happens if you don't have enough sodium? What's going to happen to your heart? What's going to happen to your brain? Huh? You can definitely get arrhythmia, right? Because you're not able to get a proper depolarization. Same thing with the brain. You can't get enough like nerve depolarization as a consequence. You're not going to have enough sodium to be able to, do a proper action potential. So you can have a coma. Some people get, seizures and die from that as a consequence. Same thing with the heart. You can throw your heart into an arrhythmic state. So we're going to talk about what EKGs look like when you change the level of sodium, potassium, calcium. So those are all going to have effects on the EKG. You can actually see it. And then if you dehydrate the person, right? You're walking through the desert, you're dehydrated, you don't have enough water. Now you become what? What happens to the osmolarity of your blood? It increases, right? Because now you have more solutes. And then what happens to your sodium? Are you hypernatremic or hypo? Hypernatremic, good. So these are the different ions that are seen in your plasma and your blood. So you're going to find lots of sodium, right? Lots of sodium, and because sodium and chloride go hand in hand, you're going to see a lot of chloride ions as well. So sodium chloride is going to be in abundance in your blood. You find other things too, like the proteins are going to be negatively charged as well, and then bicarbonate is also going to be negatively charged as well. So we're going to talk about that, especially when we get into acid-base imbalances. So hypertonic solution, that means you got way too much sodium, you're hypernatremic. Conditions that might cause that, right? Diabetes insipidus, right? You're not getting, going to be throwing off your antidiuretic hormone, right? And so if your antidiuretic hormone is off, you might see that you have way too much sodium building up in your body. And then with a hypotonic solution, right? So it's low in sodium. That means you have diluted blood, hyponatremia. And then SiADH is going to be an example of something that can cause hyponatremia, right? You're not able to regulate your sodium levels properly. Cool. Other things that can cause that. So hyponatremia, if you're vomiting a lot, if you have lots of diarrhea, that can cause that. Hypernatremia can also be a result of that too. So diuretics, nausea, and vomiting can, affect your sodium level, either reduced sodium or excessive amounts of sodium as well. So it just depends. But hyponatremia, other things to keep in mind would be too much water intake, right? If you drink too much water, you're going to be overall diluting your blood. So that's not a good situation. Water intoxication. That's basically the fundamentals of water intoxication. And if you have too much ADH, right, too much antidiuretic hormone, you're going to be retaining way too much water, and that's going to overall dilute your blood. And then the opposite is true with diabetes insipidus. You have too little ADH, and you're going to basically concentrate your blood. Bless you. So signs and symptoms. So if you have a person that has hyporeflexia, right, then they probably have too little sodium. Right? If you take a reflex hammer and you try to hit their patella, right, you're not going to see a very good response to that because they don't have enough sodium to come in to allow for proper depolarization of those neurons. So that's one thing you might see. You might also see cramps as well and overall weakness. And then on the other end, if you have way too much sodium, right, if your blood is super hypertonic, then you might see the opposite. You might see hyperreflexia. If you do, patella, reflex hammer, then you're going to see an exaggerated reaction to that, an exaggerated response. And of course, the heart is going to be affected, so you might see tachycardia with hypernatremia, way too much sodium, and your cardiac myocytes are basically getting out of hand. Now let's look at potassium. Potassium is a little interesting. Now, remember we talked about nausea, vomiting, and diarrhea. That can affect sodium. You can either get too much sodium or too little sodium. When it comes to potassium, diarrhea usually results in hypokalemia. You basically waste all of your potassium in the stool. So that's one major difference. Insulin can also affect your levels of potassium. Alcoholism can also affect levels of potassium. That's why if you guys worked in like with alcoholics at all, have you guys ever heard of the term banana bag? You guys heard of that? So a lot of alcoholics, when they come in, they have maybe have delirium tremens, DTs, or something like that. One thing you want to give them is a lot of potassium. So alcoholics can see hypokalemia, and so you want to give them a banana bag because bananas, of course, are rich in potassium. You could give the person an actual banana, but generally speaking, you're giving them potassium as a supplement. What's up? Delirium tremens is actually a result of autonomic instability. So what happens is when you're a chronic alcoholic, what does alcohol do to your brain? Besides make you feel awesome. It's a neurodepressant, right? So it's a neurodepressant. So if you're constantly drinking alcohol, it's basically inducing GABA receptors, so it's causing neurodepression. What happens when you stop drinking alcohol cold turkey one day? You have neurostimulation because GABA receptors are now going to be not affected by the alcohol, and so now you have stimulation. And so when you get delirium tremens, some of the effects are accelerated heart rate. You might also see temperature going up. So everything kind of starts going up, and then that's what results in autonomic instability. So it's not a consequence of potassium. It's actually more of a consequence of the GABA receptors, and they're not being stimulated properly. So that's why one of the reasons why you give a person, you put them into you give them benzodiazepines when they're coming off of booze. The benzodiazepines are GABA receptor agonists, so they bind to the GABA receptor, so it helps to maintain that neurodepression, right? So then the person can detox off of alcohol. Good question, though. No, diarrhea causes losing potassium. Yeah, so if you have really bad diarrhea, you're going to lose a lot of potassium as a consequence. Yeah. I'm sorry that wasn't clear on the slide here. If you have a lot of aldosterone, what does aldosterone do? It swaps one thing for another. What does it swap? What does it bring on, and what does it excrete? It allows, so you're absorbing sodium, and you're exchanging sodium for potassium. So if you have a lot of aldosterone, you're going to be increasing your sodium, so you become hypernatremic, but as a consequence, you also lose a lot of potassium in that process. You become hyponatremic. If you're using potassium-wasting diuretics, so Lasix, furosemide is a good example of that. The opposite would be spironolactone. So spironolactone is a potassium-sparing diuretic, so it works in a different way. So it helps to maintain the amount of potassium. So diuretics can throw your potassium off balance, depending on what types you're going to be using. If you have too much potassium, you can see that in a couple different cases. You can see it in burns, which is kind of interesting. If you're deficient in insulin, insulin is going to help to move potassium into the cells. So if you don't have enough insulin, you're not able to move the potassium into cells. So one thing that you see with a patient, for instance, with diabetic ketoacidosis, so DKA, have you guys ever seen, any of you who actually work in the hospital, have you seen it before? So what's one thing that you give to those patients? So what's happening with DKA? What's happening with diabetes type 1? Yeah, so it's destroying the beta cells, beta islet cells of the pancreas, so you're not producing insulin, right? So you have no insulin. If you don't have insulin, then your cells start to get starved, right? Because insulin allows bringing in glucose to the cells. If you can't bring glucose into the cells, you're causing starvation. And then because of that, you start developing ketones, because ketones can be an energy source for the brain. And so that's why you have an extra amount of ketones in the body. If you were to treat that patient, you would want to give them insulin, right? But another thing you want to give them too is potassium, because potassium, once they give them insulin, all that potassium is going to start to flood into the cells. So they could become hypokalemic as a consequence. So you want to give them extra potassium so that they don't become hypokalemic. And then aldosterone, of course, if you don't have aldosterone, right, you're not going to be bringing in sodium, and you're not going to be excreting potassium. So you're going to be building up potassium as a consequence to Addison's disease. So those are all different things that can happen. So here's an EKG. What do each of these waves represent? What's happening here at the P wave? Atrial depolarization, good. And then you have contraction during the PR section. What's happening at the QRS complex? Ventricular depolarization, good. And then between the QRS complex and the T wave, that's where you have ventricular contraction. And then T wave is what? Repolarization. So let's follow what's going on over here. So this is all. So these are the SA and AV nodes, right? And then over here at 2. So at 0, that's where you have depolarization. You have a rushing in of sodium, right? So that's the depolarization. Then over here, you have calcium coming in at 2. So that allows for the muscles to contract, the cardiac myocytes. And then at 3, you're going to have potassium being involved in repolarization. So potassium basically gets excreted out of the cell to allow for repolarization. So in other words, if you have any sort of imbalance of your ions, you can see it in the EKG. So this is some high yield stuff. You have to know it for the sake of your exam. So let's talk about potassium with hypo versus hyperkalemia. Now, if you are hypokalemic, actually, let's go to hyperkalemia because it's very dramatic when you see the T wave on a patient with hyperkalemia. You're going to see a spike in that T wave, right? Because what's happening at the T wave? You're seeing ventricular repolarization. One of the key things that allows for that is going to be potassium. It's going to be important for ventricular repolarization. So if you are hyperkalemic, you're going to see a spike or you're going to see an abnormal amount of potassium movement during ventricular repolarization. So that's why you see this massive T wave. Now, and in terms of like muscle effects, you're going to see muscle weakness, spasticity. Okay. Now, on the other side, with hypokalemia, the T wave is going to be massively reduced. It's going to be depressed. Okay, so it's going to be the opposite from hyperkalemia. And then you get this U wave, and the U wave, it's not really clear exactly what causes it, but this is one of the ideas. It involves just kind of abnormal repolarization of the Purkinje fibers. So you might see a U wave. But it really just depends also on the amount of potassium. So these are the different gradations of severity when it comes to hyper and hypokalemia. So you might see different types of manifestations of the EKG, depending on how severe the hyper versus hypokalemia is. But the most important thing is going to be the T wave. Okay? So you'll see a massive T wave if the person's massively hyperkalemic, and you'll see a blunted T wave if the patient is hypokalemic, okay? And then you might see that U wave as well. So it looks kind of like a little dimple in that T wave. So any questions on that? What's up? It does kind of look like a ventricular flutter, or a ventricular tachycardia rather, not ventricular flutter. If it was V-fib, that would just be like, you wouldn't see anything, right? That's like a pulseless individual. That person needs to get cardioverted right away. I'm not really sure about the sign pattern, to be honest with you. It's just something that you see, but you're not responsible for the sign pattern. Just know T waves. That's the most important thing on that. Be curious to look into that in more detail. So with hypokalemia, now you do see weakness, right? But you can also see cramps too. So when you see changes in these ions, know that each ion kind of helps balance out the other ions too. Right? So one thing that you see if you have low extracellular potassium, that might cause intracellular calcium levels to go higher. So it's because it involves a lot of the charges. Right? So you have the electromagnetic charge. It's going to be a little bit different. So if you have a larger potassium gradient, then that means that more potassium is going to leave. And then you get, because of the change in the charges, you have an attraction of potassium and calcium into the cell, right? Because think about where potassium lives. Where does potassium usually stay? Is it inside or outside of the cell? It's mostly inside the cell, right? So it's going to help to contribute to a more positive charge within the cell. That positive charge is thereby going to repel sodium and calcium, right, as a consequence. If you don't have enough positive charge inside the cell, now that's going to create a vacuum, sort of, right, in terms of like electronic charge. So now you get more sodium and more calcium inside the cell. If you have more sodium and calcium, that's going to reduce things like depolarization. It's also going to result in things like weakness and cramping as a result, okay? Yeah, eat a banana or go to the hospital and get yourself a banana bag. So that would be a good way to treat that. So here are the things you see with potassium, either hypokalemia or hyperkalemia. Now, when you think about calcium and potassium, both of those are positively charged. I want you to associate those with either alkalosis or acidosis. Acidosis means you have too many protons, right? You're acidotic. your pH is low, right? Also think about acidosis being associated with hyperkalemia and hypercalcemia. You can see those both with acidosis. Alkalosis, you're going to see lowering of potassium. You'll see reduced potassium, reduced calcium, and you're going to be thinking the patient might be alkalotic. Other things that you might see in terms of symptoms, confusion, drowsiness, all that is going to be involved in hypokalemia. And then you might see some GI effects as well. Now, if you have too much potassium, you might get irritability, anxiety. You'll see that EKG change, right? What's the prominent thing you see in the EKG? Spike T wave. Good, exactly. You might see diarrhea as a consequence of hyperkalemia. And diarrhea might actually be a good thing because remember, if you get diarrhea, you lose potassium. So in one way, that might be a good way to level the levels of potassium out. All right, so now let's talk about calcium. With calcium, there's a couple different forms, not really like super high yield information, but there's a couple forms of calcium. The most abundant is going to be ionized, it's free calcium. And then the second most abundant is going to be bound to albumin. So if you're checking the levels of calcium and albumin, you can actually correct for albumin. There's a couple of equations you can use, but that's beyond the purpose of this class. But know that calcium is going to be a lot of it's going to be bound to albumin as well. And then you have the complex calcium. So those are going to be like your calcium salts, calcium bicarbonate as a great example of that. Where does calcium come from? Right, so you get calcium from things like diet, but also vitamin D is going to be really important too. So when you get vitamin D, you're going to get increased levels of cholecalciferol. Cholecalciferol is going to help to increase the amount of reabsorption of calcium. You can get that increased from your renals, right? So you're absorbing calcium that way. So it's all side note. So how is calcium absorbed? You get it either through the GI tract, so you can absorb calcium that way, as well as through the kidneys. What is an important hormone that's involved in that? So two major hormones that help to balance calcium. Which are they? Do you remember from A&P? Yeah, PTH, parathyroid hormone, and then calcitonin, right? What does calcitonin do? Yeah, so calcitonin maintains the tone of calcium. If you have too much calcium, calcitonin comes in, and so it's going to help reduce the amount of calcium in the body. One of the ways it does that is by stimulating osteoblasts to build bone, and it inhibits osteoclasts because osteoclasts crush bone, right? And then PTH does the opposite, right? Parathyroid hormone is going to help increase the amount of calcium available. So one of the ways it does that is going to be through the GI tract. Another way is through the kidney. And the other way that it does that is with the osteoclasts as well. If you want to increase calcium, you can stimulate osteoclasts to crush the bone down so that now you have more available calcium floating in the system. If a person has kidney failure, so you see this with diabetic patients, patients with long-standing diabetes or hypertension, and they have renal failure, they're going to dialysis. One thing that that you'll see is that they'll have osteoporosis because they're not able to synthesize vitamin D properly. So they're going to get a reduction in calcium absorption, and they're going to be hypocalcemic as a consequence. So that's a very common theme in patients with end-stage renal failure. So these are the two major hormones, right? So parathyroid hormone and calcitonin. Parathyroid hormone increases calcium. Calcitonin decreases calcium. So that's the main thing. This is my personal mnemonic. It maintains the tone of calcium. That's what helps me remember calcitonin and what it does. Okay, so if you're hypercalcemic versus hypocalcemia. So these are going to manifest with different signs and symptoms. So if you're hypercalcemic, calcium is actually going to interfere with sodium's ability to enter the cell. So here's the cytosol that's inside, and here's outside the cell. So you have calcium outside the cell and sodium. Here's a sodium channel. If you have too much calcium, that's going to block the ability for sodium to enter into the cell. Now, what does that do? Remember, sodium is one of the most important ions involved in depolarization. So if you can't get depolarization, you're not going to get proper neuronal firing, right? You're also not going to be able to get proper muscular contraction. And so that's going to cause hyporeflexia. Okay? So think about that similar to hyponatremia. If you're hyponatremic, you don't have enough sodium in general, so you're not going to get a proper nerve conduction, right? So hyporeflexia. If you were to hit their patella, you wouldn't see much of a reaction. Same thing with hypercalcemia. If you have too much calcium, that's going to affect the amount of sodium that actually is able to enter the cell. Then hypocalcemia, it actually makes it easier for sodium to enter the cell, so you get hyperreflexia. So a patient with hypocalcemia, you're going to see tetany as a reaction to that. You're going to see tetany, and there's a couple tests that you can do, like the chopstick sign, where if you tap the person's cheek, they might start grimacing. That's because they have hyperreflexia, and that's because of hypocalcemia. So we'll talk about that in a little bit more detail. So just think about that in terms of neurons and then cardiac myocytes. So that's really important. So with hypocalcemia, it's going to be like pseudo hypernatremia. So it's going to mimic hypernatremia. So you get hyperreflexia, you get tetany, and all that jazz. So you get hyperreflexia. You can see tetany as a consequence. For the QT interval, you might see a long QT interval, which I'll show you what it looks like on an EKG in a second. And then you can see neurological disorders as well. So convulsion, seizure, right? Because you're not getting proper nerve conduction, nerve depolarization. These are the two major signs that you need to be able to remember that's associated with hypocalcemia. So the chopstick sign, that's where you tap the person's face and they start grimacing. And the other one is Trousseau sign. You put a sphygmomanometer on somebody and you start pumping up that cuff, the blood pressure cuff, and then you start seeing their hand kind of turn into like a, I don't know how to really describe it. It's kind of like the Italian, like mucho gusto, you know? So that's kind of what it looks like. So here's a video what that looks like here. So that's the chopstick sign. So you see that muscle twitching of the face from hypocalcemia, and then here's the Trousseau sign. You pump up that sphygmo, and then all of a sudden you start seeing, like you went to an Italian restaurant, you had some really good spaghetti. Cool. All right, and then this is what you would see on the EKG. Now, if you're hypocalcemic, you might see long QT intervals. You're going to see a long QT interval, and yeah, so that's what it's going to look like. It's going to look abnormally long, right? So hypocalcemia, you're going to think it looks like tetany, right? It looks like hypernatremia, and then the effects on the heart, it prolongs that QT interval. Hypercalcemia is going to narrow the ST segment. It's going to shorten the ST segment and the QT interval. So now for hypercalcemia, you know, if you're a poet and didn't know it, this is a good way to exercise your rhyming skills. So bones, stones, groans, thrones, psychiatric overtones. Those are all the symptoms of hypercalcemia. So bones, right? You have too much calcium. It's going to cause some issues with your bones. Right? Stones. You get kidney stones. Calcium is going to be one of the major components of the majority of your different types of kidney stones, which we're going to go into in more detail when we get into nephrology later in the semester. Groans. You might get some sort of like nausea, vomiting, abdominal discomfort. Thrones, because you're using the toilet a lot, you're peeing too much. And then psychiatric overtones. It's going to cause issues with the neurological system. So you get depression, things like that. What's up? Yes. Yeah. So that's one of the concerns about taking too much vitamin D, is that it could result in hypercalcemia. It's rare. You would have to take a lot of vitamin D for that to happen, but it could happen. Yeah, vitamin D is really important for a lot of things. There's vitamin D receptors even in the brain. So there's actually a link with too little vitamin D and getting things like depression, anxiety. It's even been linked to schizophrenia too, which is kind of interesting. So people who, when they're developing younger and they don't get enough vitamin D, not enough sunlight, they can actually develop mood disorders and schizophrenia in adulthood, which is kind of interesting. You can see those cardiac arrhythmias. Remember, hypercalcemia is going to mimic hyponatremia, so you get hyporeflexia, and then you get muscle weakness as a consequence as well. So here's a summary of what that all looks like, right? So if you're hypocalcemic, you might not have enough vitamin D, right? You might be a vampire, avoiding the sunlight at all costs, like myself. I get sunburned really easy, so I don't go into the sun very often. Hypoparathyroidism, right? If you don't have enough PTH, parathyroid hormone, you're not going to get enough calcium circulating in your body. If you just have malabsorption, that can be due to a lot of things. Patients that have like celiac disease, where they get GI distress if they have gluten. Patients that have had portions of their bowels resected due to maybe they had like Crohn's disease or something. They had to get parts of their small intestines removed. So those kinds of things, you might see malabsorption. Pancreatitis, you can also see with hypocalcemia. And then remember the EKG changes with that. So if you have too little calcium, that prolongs the QT interval. Too much calcium, it shortens the ST segment. Hypercalcemia, maybe you're taking too much vitamin D. You could also get hyperparathyroidism. People that take lots of Tums, if you take way too many Tums, one of the components is calcium in Tums, so that could potentially result in hypercalcemia. And if you have a tumor that's affecting your PTH, that can also cause hypercalcemia too. So this is really high yield. Remember what these all look like when you see an image of an EKG and it looks abnormal. Try to figure out what kind of ion imbalance. This is normal, right? P, QRS, T areas. If you have hypokalemia, you're going to get a reduction in that T wave, a possible U wave as a consequence. Hyperkalemia, it peaks on that T wave. Hypocalcemia, it elongates everything, so you get a prolonged QT interval. And then hypercalcemia, it shortens that ST segment. So here's another image of what that looks like, basically the exact same thing. So make sure you know all those, okay? All right, let's talk about acidosis and alkalosis. So acidosis, too many protons, right? So acidosis, too many protons, pH is going to be reduced. Right? When you think about acidosis, too much protons, I want you to also lump these two in there together. I want you to think of hyperkalemia, positively charged ion, hypercalcemia, double the charge, right? It's got two positive charges to those. So think if you have acidosis, too many protons, okay? So it's kind of a secondary effect. So if you have acidosis, you're going to get some other effects systematically, right? So you might see lethargy, right? Because remember, hypercalcemia, it mimics hyponatremia, right? So it's pseudo-hyponatremia. So if you have too little sodium, you're going to get lethargy, muscle weakness, right? Neurodepression. Now, on the opposite end, if you have too little protons and you're alkalotic, then you're going to have a reduction in your potassium and calcium levels. Because of calcium, hypocalcemia mimics hypernatremia, so it's pseudo-hypernatremia. You're going to get the opposite. You're going to get restlessness, convulsions, excitation, right? So those are going to be the major effects of those. Cool. Any questions on all of that? All right, let's jump into quizzes, and then we'll start acid-base imbalances. Are you guys having a hard time logging in? Or? All right, I'm going to go ahead and start. Those of you who weren't able to log in, you're still able to log in after I start, so let's go ahead and get into it. It looks like most of you guys got that correct, which is fantastic. Yeah, so if you give a hypotonic solution, water follows solutes. That means you've diluted the blood, right? And now within the cell, within the intracellular fluid, there's a lot of solutes in there. Water is going to now follow those solutes. So you're going to get osmosis into the red blood cell. It's going to cause swelling of the red blood cell and potentially hemolysis of that red blood cell. So what's the underlying cause of diabetes insipidus? Yeah, so not enough ADH. The distal convoluted tubules and the collecting ducts are not responding to ADH, right? So you're not getting those aquaporins to allow for reabsorption of water. So in other words, you're losing a lot of water, right? You're drinking a lot, right? That's polydipsia. And then polyuria, you're peeing a lot, right? And so if you're peeing a lot, what's going to happen if you're losing a lot of water as a consequence, what's going to happen to your osmolarity? If you're not absorbing enough water, right? If you're not absorbing enough water because you're losing a lot of water, your serum osmolarity goes up, right? Urine osmolarity. You're peeing a lot. It becomes super diluted, so it's going to go down, right? So low urine osmolarity. Urine volume is going to go way up, right? Because you're drinking a lot of water, you're peeing a lot of water. You're not retaining any of that. So you're going to get all of these things are going to happen as a consequence. Okay? And it's the opposite for SIADH. Okay? All right. So let's see. Carpopedal spasms, hyperreflexia, tetany, and then the QT syndrome, where you have elongation of that QT section on the EKG. So that is going to give you the indication that it's involving calcium, right? And then when you look at the other things that are involving like hyperstimulation, right? Hyperreflexia, all that, that's like pseudo hypernatremia, which is due to hypocalcemia. And so calcium is going to be the main deal here. So it's hypocalcemia. Okay, is that good? All right. So it looks like sodium, but it's not. It's going to be calcium as the underlying cause of that. All right, cool. So yeah, when you see blunting of that T wave, right? So blunting of the T wave and then impossible U wave as a result, then you're thinking hypokalemia. Yeah, and then you also look at diarrhea, right? If a person diarrhea has lots of diarrhea, they're going to lose a lot of potassium as a consequence. So they're going to become hypokalemic. It's a lot of water, by the way. So when you see lots of water consumption, you're thinking water intoxication, right? The major ion that's associated with that is sodium. Okay, so if you drink way too much water, you're going to dilute the blood, and most of you guys already knew that. So I'm going to shut my mouth and keep going. So think of that cute little poem. You guys remember the poem? Stones, groans, thrones, bones, psychiatric overtones, phones, drones. I don't know. So hypercalcemia. So if you think just like stones, calcium, right? So that's going to be kidney stones. So what do you have? You have what do you see with a very small amount of calcium? If you have hypocalcemia, shorter or wider? Wider, right? So hypocalcemia, you get widening of the QT interval. And same thing with on the opposite is hypercalcemia, you get shortening of the QT interval. And all this talk about diabetes insipidus and whatnot makes me want to use the restroom. So let's go take a little 5-minute break. All right. So. All right. So I posted these slides for you guys before class. So did you guys all get it already? Okay, cool. Perfect. All right, so piggybacking off of what we basically talked about in terms of like fluid mechanics and ions and all of that, this is basically part 2 of that whole discussion. So Acid-base imbalances. Is it the most exciting thing in medicine? No. Is it really important? Yes. So you're going to see a lot of this in the future when you're working with your patients, because alkalosis and acidosis are going to be, associated with different types of pathologies. So you're going to see a lot of that in the future. So these are the things we're going to cover. We're going to talk about both acidosis and alkalosis, and focusing on whether it's metabolic or respiratory. And then at the end, we're going to talk about compensation mechanisms too, because you can have compensation if you have like respiratory acidosis, then your kidneys are going to help to try to compensate for that acidosis. So the kidneys are going to try to create a more alkalotic state so it balances the pH level. And the opposite is true. If like you have metabolic acidosis or alkalosis, then the respiratory system is going to try to help compensate for that by achieving a greater amount of balance again. Right? It's all in the hope of maintaining homeostasis. So these are all the different things. And then we're going to talk a little bit about diabetic ketoacidosis and then lactic acidosis as well. So those are all going to be things we'll cover in Module 3. So what is acidosis? The quick and dirty way to look at a patient's chart and see whether or not they're acidotic is generally 7.4. That's like a nice, sweet little average. If it's 7.4, that means that they're right on mark. Right? The range, though, is 7.35 to 7.45. So if you're anything below 7.35, then you're acidotic. So if you're 7.34, you're acidotic. If you're 7.5, if you're 7.51, then you'd be alkalotic. So you'd be have a reduction in your protons. So it has to do with your pH balance. If you become really acidotic, you die. If you become really alkalotic, you also die. So you're not supposed to go beyond a certain threshold, right? And the reason why is because it's logarithmic. For every single point you add to the pH, it's going to be an order of magnitude greater, so tenfold. So 7.35 compared to 7.45 is a tenfold difference in pH. And every time you move further along the line, then that's a tenfold increase. So it's basically orders of magnitude greater. Acids. So we talked about acids. We talked about being acidotic. So that's going to be involving protons, right? So you have free protons floating around when you're acidotic. There's a couple different types of acids. There's volatile acids and there's non-volatile acids. When we're dealing with volatile acids, one great way to think about it is when we breathe, right? We're breathing in oxygen, breathing out carbon dioxide. When carbon dioxide is being transported throughout your blood, it's in the form of what? Yeah, it's up there, carbonic acid. Right? So that's the majority of your carbon dioxide is going to take the form of carbonic acid, and that's what circulates throughout your body. So when you think about carbon dioxide and carbonic acid, you can think about the respiratory system. Okay? So if you have carbonic acid, which is an acid, and you want to be able to breathe off carbon dioxide, that's going to be a volatile acid. So it's able to convert to carbon dioxide so you can breathe it off more readily when you're undergoing respiration. Non-volatile acids are going to be your stronger ones. So hydrochloric acid is a great example of that, which you find in your GI when you're digesting food. And they're not volatile, so they can't be expelled through your breath, right? So you're not breathing these off when you're exhaling. They're going to instead be eliminated through the renal system. So you excrete your stronger non-volatile acids through the urinary system. And then bases are basically things that can combine with those free hydrogen, those free protons. So if you have a strong acid, they're going to disassociate more readily than a weaker acid. Weaker acids are going to, they're going to combine a little bit more with hydrogen ions. So that's why they're not super strong. Hydrochloric acid fully dissociates when put into solution. So Other things to keep in mind here with a big picture. So breathing versus peeing. Okay, so when you're breathing off carbon dioxide. And when you're urinating, you're going to be excreting basically everything else. Okay, so that's anything else that's associated with acids and bases are going to be excreted through the renal system. Where do these acids come from? A lot of them are going to be coming in from our foods, right? So you can get a lot of different, you can get carbon dioxide from like metabolizing, especially like glucose, right? When you're undergoing glycolysis and then going into the Krebs cycle and all that, you're going to get carbon dioxide as a consequence to respiration. And so look at the equation here. On the left side, that's going to be respiratory. On the right side of the equation, that's going to be metabolic. Okay? So respiratory is anything that involves carbon dioxide. The intermediate to that is going to be carbonic acid. And then the right side is going to be metabolic, and that's going to involve bicarbonate. That's what HCO3 is. HCO3 is bicarbonate. So if you took, for example, sodium bicarbonate, baking soda, that would be one of the components of that. It would be the bicarb. So these are your normal values. Have you ever had to do an ABG on a patient? It's really painful when you do an ABG. It's not like taking an IV, right? It's when you take an IV draw from a patient, you're going from the venous system. If you're doing ABGs, you're going into the arterial system. And the best place to do it is the radial artery. And if you guys remember from anatomy, you guys worked with cadavers, right? So generally speaking, venous system is more superficial, arterial system is deeper, right? So you have to go through a lot more tissues, and there's a lot more pain fibers, nerve endings in the arterial system. So you get an ABG, you go really deep into their wrist with a needle. You're going actually at a 90-degree angle, and you're getting the arterial blood. And then when you do your ABGs, it's your arterial blood gas. So it gives you a really accurate reading of their not only their pH level, but also the amount of carbon dioxide, so the partial pressure of carbon dioxide versus the amount of bicarbonate. And so these are the normal values. So remember pH, think 7.4, and then give yourself 0.5 on one end and 0.5 on the other. So it's 7.35 to 7.45. That's normal range. PCO2, 35 to 45, kind of similar to these numbers, right? So you can kind of try to start conceptualizing. Normal range for PCO2 would be 40, right? And then give yourself 5 points as a grace range. So you have 35 to 45. And then this is the one that's kind of wonky though. So bicarbonate, normal would be around 24. So 22 to 26 is a normal range. What's going on over here with bicarbonate? Bicarbonate is a really important buffer, right? Bicarbonate is effectively basic, and so it's going to help to stabilize the pH, right? If you give somebody a lot of bicarbonate, it's going to make them more alkalotic. So if you ever take, Peacoats, or if you drink anything that helps to alleviate acidic stomach, right? Have you guys ever had Peacoats? That's the Mexican version of Tums and or Alka-Seltza. So what it does is neutralizing the pH in your stomach. If you drink a lot of those, it's going to eventually make you alkalotic because bicarbonate is one of the components of that. So that's why when we talk about blood as being a buffer, we're kind of referring to bicarb as being a component to that. And then carbonic acid, of course, is the intermediate. Okay, so that's carbonic acid. That's where you see most of your carbon dioxide is going to take on the form of carbonic acid for the most part. Lungs, you're thinking CO2. Kidneys, you're thinking bicarbonate, and basically everything else. This is not super high yield, so I'm not really going to go into it in too much detail. So bicarbonate, this is going to be primarily involved in the metabolic side. So if you talk about metabolic acidosis or metabolic alkalosis, we're going to be mostly concerned with bicarbonate levels. So let's go back to this chart. If you're looking at carbon dioxide levels, you're thinking respiratory. So what happens to your pH if you have way too much carbon dioxide building up in your blood? Does it become acidic or does it become basic? Acidic. So whenever you think of carbon dioxide, I want you to think immediately acidic, acids. One great way to think about that is a person overdosing on fentanyl or heroin or opioids. What's the thing that kills them? Respiratory depression. Why is that bad? Because you need to breathe oxygen, but also you need to breathe out carbon dioxide. When you undergo respiratory depression, you become acidotic, and that would be respiratory acidosis because it involves a buildup of carbon dioxide in the blood. You got a question? Yes. If, opposite direction. If you breathe very rapidly, you're tachypnic or you're having a panic attack, then you're breathing off all that carbon dioxide. And now you're going to become alkalotic. So yeah, you're right. You would go the opposite direction. So people that do like, you know, what the hell do they call it? It's like special type of meditative like breath work and stuff. A lot of times they're inducing like a state of alkalosis, and it can actually have like weird effects on the mind. So I don't know. Not really my jam, but some people are really into it. So yeah, that's the lungs. So carbon dioxide, the opposite end, whenever you see changes in the bicarbonate, HCO3, then you're thinking metabolic. Okay? So either metabolic acidosis or metabolic alkalosis. Okay, so yeah, bicarbonate is the most important thing here for metabolic acidosis and alkalosis. If you have very low bicarbonate, remember, bicarbonate is considered a base, right? It's basic. So if you have too little of it, then you're going to be acidotic. So that's metabolic acidosis. If you have too much bicarbonate, say you drank a lot of Peacoats or you drank a lot of Alka-Seltzer, that's going to crank your levels of bicarb up, and then you'd become alkalotic as a consequence. And then we talk about the equation shifting either to the left or to the right. So if you have too little bicarbonate, right, you have too little bicarbonate, eventually you're going to shift the equation to the left. And then too little bicarb results in increased amounts of carbonic acid. So that's why you see metabolic acidosis. Carbonic acid is going to go up when you have too little bicarb. It's basically, yeah. And then the opposite end is true. It shifts to the right. If you're alkalotic, that means you have increased bicarb, and then you're going to have decreased carbonic acid as a consequence. Okay, so that's what creates that alkalotic state. You have a reduction in your carbonic acid levels. Oh, I was supposed to play that slower. So alkalosis, reduction in free protons, free hydrogen, increase in bicarbonate. And then acidosis, increase in your protons in the form of hydrogen, increase by carbonic acid, right? So that's when you become acidotic as a consequence. So let's talk about when we're referring to uncompensated versus compensated. So we're going to focus first on uncompensated acidosis and alkalosis. When you have metabolic acidosis, your pH drops, right? Below what value? 7.35, right? If it drops below 7.35, you're acidotic. And then your bicarbonate levels are also going to be reduced because bicarb is considered basic, right? So reduction in basic bicarb causes acidosis. Opposite, right? Increased pH, alkalotic, increased bicarb. Now this would be considered uncompensated metabolic acidosis versus alkalosis. So this is not coming into, the lungs have not yet come into play here to try to balance this back out again. Oh my goodness, that is such a great question. I have to really look into that. Can you answer that? Oh, that's interesting. So the lactic acidosis from the pain, from the MI, right? So you have the MI, you have the lactic acid buildup, the pain, and then to help reduce that pain, then you administer bicarb to reduce lactic acidosis. Right. Okay. That makes sense. Yeah, of course. That's interesting. Okay. Well, that's the benefit of being an EMT, right? You get to see all that stuff firsthand. I've never really worked in the emergency room before, so that wasn't really my field. So thanks for answering that. That means that, like, for instance, if you're undergoing respiratory depression, that would be, you would get respiratory acidosis, and the kidneys haven't started to come into play yet, so it would be uncompensated because it's only involving carbon dioxide at that point. If you have metabolic acidosis, for multiple different reasons, we'll talk about those later. Mud piles could be due to like ethanol toxicity, it could be methanol toxicity, it could be uremia. So different things can cause metabolic acidosis. That's only involving, at that point, metabolic processes and has not yet involved the lungs. To be able to counteract that, what do you think the lungs would do to compensate? If you had metabolic acidosis, what would the lungs do to be able to counteract the effects of the acidosis? Yeah, you start hyperventilating because now you're breathing off the carbon dioxide, and then you start trying to reduce the pH, or increase the pH level as a consequence. Yes, that's one of the reasons, because diabetic ketoacidosis, you start getting Kussmaul's breathing and stuff, and yeah, it has a lot to do with that. Cool. So right now we're focusing on uncompensated, so it's only using one or the other. It's either respiratory or metabolic. So let's talk about uncompensated metabolic acidosis. What would the pH be? Down. Good. What about metabolic alkalosis? pH? Up. Right? Now what about bicarb levels and metabolic acidosis? Up or down? Did you say down? Good. So it would go down. What about metabolic alkalosis? pH? Bicarb? Up. Right? So remember that bicarb is associated with being basic. So the more bicarb you have, the more alkalotic you become as a consequence. So this is the part that gets a little annoying, was the whole like shifting to the left, shifting to the right, and all that jazz. So let's just kind of go through some of these practice scenarios. So you have, let's look at PCO2. That's the partial pressure of carbon dioxide. So we're thinking what? Respiratory or metabolic? Respiratory. Good. So you're going to be looking at this side. This side is respiratory. This side is metabolic. So if you're hyperventilating and you're breathing off a lot of carbon dioxide, what's going on with your carbon dioxide levels at the end? So it's going to go down, right? What's going to happen to your proton levels? So it's going to go down, right? Because now you're breathing off carbon dioxide, you become more alkalotic. Your overall level of protons are going to be going down. Okay, so in other words, you get this shifting to the left. So in other words, carbon dioxide, you think about it as like you're removing the carbon dioxide. So you're removing the carbon dioxide. Carbonic acid is going to try to replace the carbon dioxide. The protons are going to try to turn into carbonic acid. So then everything basically moves leftwards, right? And so you're breathing all the carbon dioxide out, everything kind of moves to the left, and then you get an overall reduction of protons as a consequence. So now you're becoming more and more alkalotic. Hypoventilation, you're going to get what? Happens to the carbon dioxide? Goes up, and then because now you have increased carbonic acid as a consequence, you're going to get what in terms of protons? Going to go up, right? Because now you're becoming more acidotic. So that's what we're talking about when we say the equation shifts to the left versus shift to the right. This becomes a little bit more complicated when we start talking about compensation, but we're still focusing right now on uncompensated. So uncompensated respiratory acidosis, you're going to be looking at your PCO2 levels. Okay? What are your normal CO2 levels? What's the range again? Yeah, think 40, so 35 to 45 is going to be normal range for CO2. If you have too much CO2, right, you are maybe around, say, 47, 48, 50 in terms of partial pressure CO2. That means now you are acidotic, right? So now you have respiratory acidosis. If you have Too little CO2, you're hyperventilating, you're breathing really rapidly. Now you're becoming alkalotic, right? So hyperventilation, alkalosis. Still not involving metabolic process to balance things out. You're not involving, bicarbonate yet. If you started to, if the kidneys started, retaining or excreting more bicarb, then that would be compensation. You would start compensating for this primary acidosis, primary respiratory acidosis, or primary respiratory alkalosis. So still uncompensated. What's going on with respiratory acidosis? pH levels are down. What about respiratory alkalosis? It's the opposite. What about PCO2? What's PCO2? Is in acidosis, PCO2 is what? Up or down? Up. Good. And then opposite for respiratory alkalosis. You're breathing off all that carbon dioxide. You're hyperventilating. So here are a couple charts that show what that looks like. So this is a good summary of all the above, everything we just talked about. So with metabolic acidosis, pH is down. Respiratory acidosis, pH is down. Metabolic alkalosis is the opposite. pH is up and up for respiratory alkalosis. Metabolic acidosis, bicarb is down. Metabolic alkalosis, bicarb is up. Note, there's no compensation yet. This is primary process. It's uncompensated. So PCO2 is not going to be changed. It's going to be within normal limits. It's going to be within that normal range. Respiratory acidosis, involving partial pressure of carbon dioxide. Acidosis, increased carbon dioxide. Alkalosis, reduced carbon dioxide. Again, you're not seeing compensation yet on the metabolic side, so bicarb levels are going to be normal, within normal limits, no change. All right, so let's talk a little bit about compensation. This is where things get a little annoying and a little complicated. So metabolic acidosis, what's going to happen with compensation? The lungs are going to try to compensate for that by blowing off more carbon dioxide, by reducing carbon dioxide. So what's going to happen? Equation is going to move to the left. What is the carbon dioxide level going to look like? Up or down? Yeah, you're breathing it off, so it's going to go down. What's going on the metabolic side? So the metabolic side, you have your protons, right, and bicarb. So your metabolic acidosis. So the person is going to start losing their hydrogen ions as a consequence of this compensation. So overall, the hydrogen ions are going to start getting reduced. They're still going to be acidotic, though, at the end of the day. But they're able to lose these hydrogen ions because when you release carbon dioxide, it's going to basically reduce the amount of free protons. And then bicarb is also going to go down as well because it's a metabolic acidosis, so their bicarb levels are going to be affected. So you're going to see every single side being affected. You're going to be seeing metabolic side and the respiratory side being affected when you have compensation. Now, with metabolic alkalosis, you're going to have a lot of bicarb. You're going to have reduction in protons. Your pH is going to go up. Then you're going to hypoventilate, so you can try to balance things out because remember, carbon dioxide, acidic. So what's going to happen to your carbon dioxide level when you hypoventilate? Going to go up, right? And so you're going to see all the arrows pointing in the same direction when you see compensation. So alkalosis, metabolic, you're going to already see an increase in bicarb. And then with increased carbon dioxide, it's also going to help to increase the number of protons available. Okay, so you can try to balance out the alkalosis by increasing the amount of protons available. Does that make sense? I know it's a little confusing, but it's easier when we start doing, I'm going to show you a trick in a second that's going to help you figure that out with relative ease. So let's talk about respiratory acidosis. So respiratory acidosis, carbon dioxide levels, right? If you're acidotic, you're hypoventilating perhaps, right? So you have a buildup of carbon dioxide. Then the kidneys are going to try to balance it out by increasing the amount of bicarb, right? So when you increase bicarb, that's going to help to make things more alkalotic, as a consequence. So what's happening with the carbon dioxide level? Carbon dioxide level, because the person has respiratory acidosis, is going to be increased, right? And then you have the compensatory mechanism on the metabolic side. So what's going to happen to the free protons? Right, the free protons are going to go down because that's the compensatory mechanism, right? And what's going to happen with bicarb? No, it's going to go up because the kidneys are trying to compensate for it. So the kidneys are reabsorbing bicarb so that it can basically help to reduce the protons. Because right now you have respiratory acidosis. If it was uncompensated, then the hydrogen protons would be elevated. But because you now have a compensatory mechanism taking place, it's going to help reduce the overall protons. Now, with respiratory alkalosis, maybe you're hyperventilating. What's going on with the carbon dioxide? It's going to be decreased, but then your renal system is going to kick in to help compensate for it. So you're going to, if you have alkalosis, you don't want to bring on more bicarb, right? So what's going to happen to bicarb levels and then subsequently hydrogen levels? So you're going to want to increase your protons, right? And you're going to want to decrease the amount of bicarbonate as a consequence, right? So this is the compensatory mechanism over here on the right. Does that make sense? Okay. So here's a chart that shows what all that looks like. Note, this is important. You're only fully compensated when the pH is restored to balance. Otherwise, when you have a compensated acidosis or a compensated alkalosis, the person's still going to be acidotic and they're still going to be alkalotic, respectively, right? So that's why the arrows here, it's still pointing in the same direction, but it's just not as much so. It's not as dramatic because there's a compensatory mechanism helping to reduce the severity of either acidosis or alkalosis. So uncompensated metabolic acidosis, you're going to have a large reduction in pH. If it's compensated, you're going to have a lesser reduction in pH, right? If it's uncompensated respiratory acidosis, pH is vastly reduced. And then if it's compensated by metabolic compensation, then it's going to be slightly reduced. PCO2, if it's compensated metabolic acidosis, you're going to see this PCO2 being reduced. How? Hyperventilation, good. If it's uncompensated respiratory acidosis, PCO2 is going to be really high because the person's hypoventilating, so they are accumulating carbon dioxide. Then if it's compensated with compensated respiratory acidosis, so you have increased PCO2, the CO2 levels are still going to be high, right? Because they have their respiratory acidosis, it's going to have increased PCO2, but now the metabolic side is going to kick in to help try to buttress that. So this is a good chart for you to kind of gloss over to help you, kind of piece all the parts together so you see what it looks like when you have uncompensated versus compensated mechanisms coming into play. And then this is all the opposite as well. So here's the opposite taking place. So these are really good charts to help summarize everything we just talked about. So let's talk about this algorithm. This is a really good way to do a quick and dirty, quick and easy way to find out if it's uncompensated versus compensated alkalosis or acidosis, and if it's respiratory or metabolic. Okay, so let's go through it one step at a time. First thing, you look at the pH. Is the pH low or is it high? If it's low, you automatically know it's acidosis. Right? If it's high, it's alkalosis. Okay. Next, you look at the number of arrows and seeing what's being compensated. So let's go through this example over here. So what's going on with this person? Are they acidotic or alkalotic? This person is acidotic, right? So they have a low pH. Now let's look at the other things that might be off. So let's look at the PCO2. Is that within normal range? No, so that's up. Okay, so the arrow, let me draw this out here. So we got down arrow here. PCO2 is up. And then what about their bicarb levels? Is that normal? No, it's elevated, right? Okay, so 3 arrows you see on this person's chart. So you put 3 arrows down. So if you count 2 arrows, if it was only PCO2 or if it was only bicarb, then that would mean it's uncompensated. That means it's either respiratory acidosis or it's metabolic acidosis. But if you see 3 arrows, then you're seeing compensation taking place. That means this person might have, I don't know, respiratory acidosis, but now the kidneys are coming into play to help increase bicarb levels so they can neutralize the pH, right? So that means there's compensation with 3 arrows. Then the last thing that you do is you see if the arrows are pointing in the same direction as the pH. So you can make an M. You can say pH level is down, and then the other arrows are going up, right? So if it's going opposite directions, that's going to be respiratory. If it's in the same direction, it's metabolic. So think about making an M. So if each of those arrows were pointing down, then that would be metabolic acidosis. Compensated metabolic acidosis. If those arrows were pointing in opposite direction, now we're thinking it's going to be respiratory. So what's the answer for this? Huh? You say compensated respiratory acidosis. Great. So we're going to do a bunch of examples of this. So you can, this is, like I said, this is quick and dirty. It makes it very easy for you to solve these types of problems. So let's do a couple examples. So go ahead and team up and let me know what you think. Team up with a buddy or three buddies. I'll give you 2 minutes on this one. All right. Are you guys ready? Okay, cool. So let's start with the first part here. So what's going on with the pH? It's low. Good. What about the PCO2? Good. What about the bicarb? Normal. All right, so what's happening here? Is it compensated or uncompensated? Good. It's uncompensated. And what's the primary mechanism involved here? Right. Carbon dioxide is going to be respiratory. And then what's the pH? Acidosis. So it's uncompensated respiratory acidosis. Okay, good. All right, let's do the next one. I'll give you a minute to do this one, so now you got the hang of it. Work with your buddies. Come on, guys. Make friends with your classmates. Exchange numbers. You need drinking friends, you know. This is when you meet them. It's when you're in college. Drinking friends, drinking water, you know. Tea. Go to the tea house. Go to a coffee shop. And I don't think it was a dry campus last night with all that rain, you know? I don't know. Thanks for laughing. That was so lame. All right, so what is the answer? So let's just go through it. What's going on with the pH? High, good. What's up with the carbon dioxide? High. All right, what about the bicarb? High. All right. Arrows pointing all in the same direction. 3 arrows at that. So what is it? Compensated. So it's 3 arrows makes an M. So now we're looking metabolic. And then it is alkalosis. So this is compensated metabolic alkalosis. The bicarb levels are high, so that's why it's metabolic. And then the lungs are trying to make up for that by increasing the amount of carbon dioxide in the blood, so it helps to reduce the pH. Okay? So that's the quick and dirty. It's very, very straightforward. That will help you a lot on your exam and other practice problems too. So let's talk about the underlying mechanism of, well, not the underlying mechanism, but kind of what's going on with the other ions involved, right? So remember last section I was talking about calcium and potassium. They're both positively charged. If you're acidotic, you have lots of protons. Also think about that being involving potassium and calcium. What's going on with protons? If you have too many protons, they're going to displace potassium. They're going to enter into the cell. Potassium wants to be in the cell, but now it's got all that extra positive charge, so it's going to be repelled from the inside of the cell. And the opposite is true. If you have too little hydrogens, hydrogen is going to go to the extracellular space, okay? And then in the extracellular space, potassium is going to want to enter into the cell, being repelled by the positive charge of the hydrogen, and now you're going to be hypokalemic. And then basically the same thing is happening with calcium as well. Very similar type of mechanism. We measure free calcium. So just think that when you have acidosis, think that it's going to be increasing your calcium levels. What happens to your sodium levels? It gives you a pseudo hyponatremia, right? So if you have too much calcium, then you're going to have pseudo hyponatremia. You're going to have weakness. You're going to have reduced reflexes, hyporeflexia. Then if you're alkalotic, you're going to have hypocalcemia. Hypocalcemia mimics hypernatremia, so it's pseudo-hypernatremia. You're going to have tetany. You're going to have increased reflexes. Patellar reflex is going to be exaggerated. You're going to have tetany as a consequence. Okay? So here's a summary of what that looks like. Think protons, acidosis. Think lots of potassium, lots of calcium. Because of the pseudo-hyponatremia, you get hyporeflexia, you get muscle weakness, you get decreased excitability of the central nervous system, and then you might get coma, lethargy, confusion, etc. Opposite end, alkalosis. Too few protons, right? That's going to also cause too few potassium ions and too few calcium ions, because hypocalcemia mimics hypernatremia. You get tetany, hyperreflexia, muscle spasms. You also get excitability of the central nervous system. So you get restlessness, convulsions, etc. Any questions? All right, let's go through some practice questions then. We got 10 minutes. Should be enough to go through every single one of these, I hope. All right, cool. Let's go ahead and get on with it so we can get out of here. True story. Just kidding. So what happened? Respiratory depression, right? So it causes what? Acidosis, respiratory acidosis, right? This is kind of what kills the person, right? They undergo respiratory depression. That's the underlying mechanism of how they die, right? So they're not able to breathe in oxygen, but they're also not able to breathe off carbon dioxide, and then that makes them acidotic, right? Because carbon dioxide is associated with increased acid. If you have buildup of carbon dioxide, so most of you guys got it right. All right, so what happens when you're acidotic? You have lots of protons. You also have elevated potassium, right? And elevated calcium levels. Most of you guys got that right. So hyperkalemia, hypercalcemia. Because of the hypercalcemia, what would happen? What would be the symptoms of that? Hypercalcemia has stones, groans, bones, psychiatric overtones, clones. What else happens too? It mimics hyponatremia, which means you would have hyporeflexia, right? So all those things would happen as a consequence. All right, these are the ones that are a little bit more complicated. So I made this way too long. I don't think you guys need a minute for that. So all right, good job, guys. That's awesome. Nice. So respiratory acidosis. All right. So you look at the pH first, acidotic. Then you look at the other values, and bicarb is normal, right? So the only thing that's off is the carbon dioxide levels. So elevated carbon dioxide, the patient has respiratory acidosis. One minute is way too long for these. I'm going to make them shorter. All right, so pH 7.6. What's that? Alkalosis, right? And then PCO2 is abnormal? No, it's normal. Good. And then bicarb is off, right? Bicarb is elevated. So this is going to be a metabolic alkalosis. All right, let's do two more, and then we can get out of here. All right, so how many arrows were there? Those 3 arrows. So that means compensation is taking place. And then were they pointing in the same direction? Good, so metabolic. All right, and last question. All right, how many arrows? Good, so 3 arrows pointing in the same direction or opposite? Opposite direction, that's all you need to know. Cool. All right, guys, good job today. I'll see you all on Friday. Have a great day.